national rural health care in general, talk a little bit about our state, and then lastly talk a little bit specifically about CMH. In rural America, we see people that are generally vulnerable populations. We take care of a large share of our 65 and older people on Medicare, Medicaid. In our county, we do have some poverty in our county. Our county is compared to the state average. We have lower income compared to our state average in our county. Obviously, rural American geography, we're isolated, and we have uninsured. Kansas has not passed a Medicaid expansion that would kind of fill that gap into when people no longer qualify for Medicaid to being uninsured. And we have about a 10% uninsured rate in our county. And that generally reflects in your uncompensated care at some point in your finances. Heart disease in small town America is 56% higher than the metropolitan areas. And to say it more frankly, 26,000 more deaths because of that. Respiratory disease is higher. Accidental injuries, unintentional injuries are 37% higher. Although cancer fatalities have declined nationwide, but they fell at a slower rate in rural America. And there's also a widening gap of almost 3 years now in life expectancy from an urban dweller to a rural dweller. And kind of looking at between urban and rural communities, the percentile ranking, we'll have a higher rate of people that are over 65 that reside in rural America. Typically, we'll see more diabetes. We generally will see more veterans that reside in rural America. We take care of those folks. Access to primary care is lower, although I wouldn't say that is the case here for our county. I think we have great access to primary care. And then access to mental health is generally lower in rural America than you will see in urban areas. If you look at a map to kind of illustrate by county, with the Medicare patients with 6 or more chronic conditions, here's Marshall County. We're actually a little darker than our counties to the east and to the west of us. So that means we have 10 to 12% of our population, Medicare population, has 6 or more chronic conditions. Just kind of demonstrating the need for more health care in rural America. Obviously, many of your rural communities have lost their labor and delivery services. It is a very hard service to maintain with what it takes to maintain labor and delivery. It takes a lot of human capital to have labor and delivery, and it's probably no shock to many that many of our rural hospitals have given up labor and delivery, or if their hospital have closed, or they're making decisions about operations and what can we support, and so on. And so it's not a surprise that many places have given up labor and delivery. So it does create pockets in our country that you got to go a long ways to find a labor or upset big hospital. More than 200 maternity wards have closed in that time frame there from 2004 to 2014. It's even more than that now. Higher rates of childbirth-related hemorrhages, higher rates of maternal and infant deaths due to these maternity deaths. Half of the rural women in rural communities live more than the recommended 30 minutes from a hospital offering maternity services. This is some graphs here of the decline in hospitals that provide obstetric services, and also here, this one here, kind of illustrates. Here's they call them micropolitans, larger than the rural communities, but even they are losing their labor and delivery. As I noted, labor and delivery it's hard to continue. It takes a lot of human capital, it takes a lot of people involved, and so it has created problems in our country with places that are willing to do obstetrics. Just some more of the difference there. 59% of the nation's rural hospitals provide OB services today. So 40% that do, 60% of rural hospitals that don't. And obviously it creates longer drive times to get to these hospitals. Just some more information about the hospital closures in rural America. So since 2010, about 150 hospitals have closed in our country. Obviously that creates a lack of access, that creates loss of economic vitality to our rural community. And obviously there's been well documented recently, a lot of articles that have looked at the plight of rural hospitals in rural America, is that 46% of the hospitals lose money. And there are a variety of reasons for that. Reimbursement, sequestration, many of them are low volume. Insurance has moved to a lot of high deductibles. There was a recent statistic that we read that I think, I don't know if it was 50 or 60% of the American population cannot come up with $400 to pay for care. If they had to write a check for $400, it's a hardship for a lot of folks. Kind of just of the rural communities in our nation, the states. Kansas does lead the nation and hospitals that have negative operating margins, and that's been well documented as well. Hospitals risk for financial distress in 2019, we had 15. There's been 8 more closures of hospitals in 2023. 700 are risk at closing currently. Kansas has 62 of those. 360 hospitals are at immediate risk for closing. Kansas has identified 31 rural hospitals that are at risk for immediate closure. 8 Kansas hospitals have closed since 2015. Kind of looking a little bit at CMH over the last 5 years. It's kind of hard to see, but over the last 3 years, we've had about $1.5 million in uncompensated care that we've written off. Uncompensated care is 2 buckets. One is our charity care. People do provide a financial application to qualify for charity care. The other bucket is bad debt. When we don't hear from people, or people don't set up a payment arrangement, they go to collections. And this year, we're going to outpace 1.5 pretty easily this year. I think we'll be closer to 2 million by the time we get to the end of the year of uncompensated care. This is our operating income over the last 5 years. You see the big dip there, or increase there, was during COVID. A lot of hospitals got COVID money. We did as well. We received paycheck protection for our employees. We also got a COVID grant as well, and that was reflected in 21 and 20. Sales tax for CMH. We've identified 85% of rural hospitals in Kansas do receive some sort of tax support, either through a meal levy or through a sales tax, or some hospitals are part of a hospital district, taxing district. Just around us, Onega receives about $1.8 million. Clay Center receives about $600,000. Meanwhile, county hospitals are also been receiving a sales tax for the last 10 years, and they receive about $1.1 million to split between Sabetha and Seneca. I think Seneca gets 55% of that, and Sabetha gets 45%. A half-cent sales tax. We've had this half-cent sales tax in place for the last 5 years, and it works out to about 50 cents on a $100 retail purchase. If you look at sales tax in our county and around Marshall County, sales tax in Marshall County remained at 8.6%, as it has been for the last 5 years. It would still be lower than the sales tax rate that's in Seneca. They're at 9%. Similar to Washington at 8.5%. Manhattan has 9.15%. Wamego is at 9.2. Junction City, surprisingly, is the highest sales tax rate in Kansas. Them and Leavenworth have 11.5% sales tax. Blue Rapids is currently at 9%. Waterville is at 8.5%. Sales tax does not rest solely with property owners and citizens. It does have the ability for out-of-town people to come purchase things and help pay the tax. It has provided approximately $1.1 million per year to CMH. And then the half-cent sales tax was similarly written as it was 5 years ago. Will come up for another vote again in 5 years. What we've seen here in the last couple of years, the inflationary environment has really affected our cash position the last couple of years. Everything is just more expensive. We've very conscious effort to try to be competitive with our wages for our staff. The workforce competition is always challenging from every job class that we have, whether it's housekeeping, dietary, nurses. It's a fierce competition out there. We're seeing, with the changing rural health care reimbursement, especially with Medicare Advantage. That's privatizing the Medicare program. That is very difficult to work with. A lot of pre-authorizations, a lot of claim denials, and it's just they deny it, and then we have to go fight to get the claim turned around, and it's very labor intensive. We're also, as I noted earlier, we're seeing a lot more higher deductibles with folks, a lot of first dollar costs. It's not uncommon to see a $10,000 deductible that people have to satisfy first before insurance pays, and so on. IT and EMR capital expenditures. There's been a lot of federal mandates with EMRs and interoperability and those kinds of things, and we have to adopt those. They are not free. They cost a lot to get those enhancements and updates. And IT, it's continual to try to keep the bad actors out of your networks. It's just a constant fight. You have to upgrade, buy new firewalls, subscription-based everything. When I first started in 2006, we had a staff of 1 IT person. Now we have 3 staff members and a host of more appliances everywhere. If you look at your networks today, everything resides on your network, whether it's video surveillance, whether it's telephone, your EMR. Everything is on our network anymore, and you really got to have a robust network in today's environment. We have benchmarked our operations to other critical access hospitals to kind of say, well, are we a high-cost hospital, or what's our costs in relation to other hospitals? And I know this is not very well seen, but this is a group of Heartland Health Alliance members. There's about 53 hospitals, critical access hospitals that are in this list, and we're right here. This is our per-day inpatient cost, and we had the lowest per-day inpatient cost with our cohort there of 53 other critical access hospitals. But we always have hope in rural America, or at least I do anyways. We know rural providers, we do a lot with a lot less. Many of our people wear different hats to try to make things go with hiring additional bodies. We know we come with a good rural work ethic. We like to use our rural engineering where possible. We have fortitude and make it through the challenging times. But we also have been able to demonstrate that our rural hospitals, we have higher quality of care, we have higher patient satisfaction, we can and are cost effective, and generally we'll use fewer resources doing it. And we won awards just for those facts there of higher quality, high patient satisfaction, and lower cost. Healthcare is fundamental in rural America. It's as important as any form of infrastructure. As very proud of our physicians that we have on staff at CMH. It's a big help to what we do each and every day. And our nurse practitioners, very well experienced, a lot of them many years of experience, and they're a big advantage to our operation as well. We've been able to really grow our specialty and outpatient clinics. We have over 13 different specialties, and that's a big help to make sure people don't have to travel to get their care. We have cardiology in our hospital 2 days a week, and that's really important. There's oftentimes that they consult on the inpatients and consult patients in the ER. We know if we have a cardiologist coming tomorrow, we can get a consult and keep that patient, and so it really adds a lot. We have orthopedic surgery once a week, along with all the other specialties that come to our facility. We've been a top 20 hospital for the last 3 years, and as I said before, that involves our quality scores, that involves our patient satisfaction, and also our cost effectiveness to win those awards. And it's really gratifying to be recognized. There's about 1,300 critical access hospitals in our country, and we've been a top 20 for the last 3 years. We've been a top 100 hospital for the last 8 years. We've been a 5-star rated hospital by CMS, and there again, that's largely patient satisfaction scores. It's conducted by a third party, and we've been a 5-star. Right now, we're currently a 4-star. They changed their formula a little bit for rural hospitals since they were performing so well, and some of the urban hospitals weren't, so they downgraded rural hospitals a little bit so they wouldn't win all the awards all the time. Byron Guys, former owner of the Marysville Advocate, when I was doing some research and reading some articles way back in 1958, wrote that no doubt there will be trying times, but if every person remains loyal to the hospital, it will serve as one of the greatest needs this community ever has had and will always need. Let us resolve now to ever work for the best interests of the hospital because it belongs to everyone. In 1958, when they were forming the nonprofit hospital, they had a membership drive, and it was kind of a capital drive, I also believe, at the time. And they had $100, you could become a member of the CMH nonprofit corporation, and it's still $100 today. Anybody can become a member, and we have an annual meeting in April, and we vote on, members can vote on board of directors and also bylaw changes if there are any. Those are about the two perks that you get for being a member of CMH. If we were to dissolve, the members do not get a cut of the proceeds. They do not give a dividend check every year. So it's not a stock ownership, it's just a member ownership. And so there's no remuneration. If the hospital were to close or dissolve, it has to be approved by the Attorney General of Kansas since we're nonprofit. So they have to approve the dissolution plan, and however if there's proceeds, and generally what happens, another nonprofit gets the money and uses it for furtherance of healthcare is generally how it goes if there's a sale or something of that nature. So the ballot question will read, shall a retailer's sales tax in the amount of 0.5% be continued in Marshall County, Kansas, the proceeds of which will be to support the provision of healthcare services by CMH. The continued collection of said sales tax shall commence April 1st, 2025, and terminate upon the first to occur of the following: 5 years has elapsed since imputation of the tax, or CMH has merged or been purchased by another entity, all pursuant to the Kansas statute of 12-187. So we're asking you today to vote yes for the sales tax, continuation of the sales tax. We want to help keep our pulse strong, and we continue to be here for the folks that choose to live in Marshall County. And just say thank you to the great citizens of Marshall County for the support, and we are definitely grateful for that support. One of the questions that we've heard at a couple of the town halls is, what do you do with the money? And what have you done with the money of the sales tax money? And if you go back to the ballot question, it says that we'll support the provision of healthcare services. And so we don't really earmark dollars to go for pieces of equipment or for salaries. If you look at the annual report there, there's a pie chart, and it kind of says where the money goes. It knows that 50% goes for wages and benefits, medical supplies, is another big chunk. The other ones are utilities and uncollectible accounts and other expenses. And so really, the money goes to support healthcare services, and it's not really earmarked individually for particular purposes such as either equipment or salaries, or you could probably say look at the uncompensated care. It's $1.5 million. We could say it helps that for our organization as well, but it's generally not earmarked for any particular purpose other than what I just said.